Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features Dr. Stephen Horwitz from the Memorial Sloan Kettering Cancer Center in New York, Dr. Francine Foss from Yale Medical Center in New Haven, Connecticut, and Dr. Barbara Pro from Northwestern University in Chicago. They will be answering questions posed during a recent symposium on new advances in T-cell lymphomas management held at the annual hematology meeting. This episode is part of a larger educational program titled Addressing Clinical Challenges in T-cell Lymphomas Through Biomarker-Driven Therapy. For more information on the presenters, along with a link to the complete program including downloadable slide sets and expert commentary, an on-demand webcast, and a healthcare professional resource guide, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
So the first question is, what is the percentage of CD30 positivity in cutaneous T-cell lymphoma that you use to inform brentuximab use?
Because of the experience both at Stanford and at MD Anderson, and the kind of issues with the assay and the issues in CTCL, you have multiple lesions, you may do multiple cuts or only have one cut that you're staining. You don't know what the CD30 expression is in other lesions that you didn't biopsy. There are responses in patients that are CD30 negative. So I don't have a cutoff. I just require some. Like if my pathologist says that there's weak CD30 staining, because they know that if they give me a number, not really kind of specific, if I go back and haunt them, the number might change. But they'll say that there's weak expression. I would treat that patient. I would at least give that patient the opportunity to see how they do. I mean, again, if they're not responding, I wouldn't obviously keep them on the drug. But I think we're hard pressed at this point in time to know what that lower cutoff is, because we artificially set it at 10% for the ALCL study. We didn't look at the lower numbers.
And here's a straightforward one. Mycosis fungoides relapse post-allogeneic transplant, previously received brentuximab, mogamulizumab, whole body radiation, and photopheresis. What would you recommend now?
Relapse after allo. I guess it depends on what the relapse is, what the stage of the patient is, whether they have blood involvement, tumor lesions. I would biopsy the tumor lesions, again, to look at expression of markers. I've been very successful with brentuximab. I've had a lot of really great kind of rebound responses with brentuximab after allo transplant. So again, I think, you really have to look at the disease compartment that you're treating and, obviously prior therapies.
I actually have a question, Steve.
Yes.
We did not discuss ALK inhibitors in positive anaplastic large cell lymphoma. What has been your experience? And I know there was a randomized study comparing chemo plus BV versus chemo plus an ALK inhibitor in pediatric patient with ALK positive disease. What has been your experience? What are your thoughts?
Yeah, so we have little experience. So we've used them in isolated cases in the relapse setting. We recently had a patient that we were consulting on remotely with CNS relapse, and they did transiently respond to one of the alectinib, one of the ones that crosses the CNS. So I think we've seen mixed. We have not seen 90%. We've had some responders and non-responders, some PRs that have been less durable, but also some quick responses. I don't know if anyone's here. I don't know a lot of the data. My understanding of the pediatric study is there was some early toxicity. I don't know if this I know sort of secondhand. So if someone knows better, I welcome them to shout out. There was some early toxicity, maybe thrombosis or catheter-associated thrombosis in the crizotinib arm, and that arm was stopped early, not due to lack of efficacy. But that's all I know about that study.
So, Steve, what do you think the future is for CD47 and CTCL?
I don't know. What the data you showed and what we've had is really the phase one. So there's the TTI-621, which is a SERP alpha decoy receptor, which has some single agent activity, particularly a couple of CRs and some long responders in people with Sézary syndrome. So I think there was a second dose escalation up to 2, like what you showed was 1. So I think we'll kind of see where that goes and whether that goes towards a single agent. My guess is those probably need to be combined to have maximal efficacy. And there is a CTEP-sponsored study led by Michael Kotodos from Stanford combining mogamulizumab with CCR4 antibody with magrolimab, CD47 antibody. So I think that's an interesting study, and that's sort of ongoing, and that would be available for patients. But again, the idea that you're using a more targeting antibody in addition to a 47 drug. Have you been using Aza-Rev? So I assume that means lenalidomide. in AITL patients who relapse post-auto or not eligible. I don't know if that means lenalidomide or romidepsin in AITL patients who are relapsed post-auto or not eligible for auto. So maybe take either of those.
I have not been using it because I think approval is a big challenge, right? Because this combination, as you know, is still being looked at. So I cannot get the approval of 2 drugs. So I have tried, but have not been successful. So I've not treated anybody.
We had a patient on the azaromi study who failed autologous transplant, had a complete response to the azaromi and was able to move on to an allogeneic transplant. And by the way, he was like 75 years old. He actually did extraordinarily well. I mean, he had a very, very deep, good response with fairly aggressive disease at the time he started the azaromi. So I think it could be a great salvage regimen to get people to allo.
We have some more questions. This one's for Dr. Pro. Is there a role of ASCT in patients who receive CHOEP up front? It looks like the 5-year overall survival rates are quite similar in patients who receive CHOP plus auto versus CHOEP based on historical data.
So most of the data with CHOEP, actually, most of those patients, with the many Nordic studies that have been done, those are the patients who actually went on to receive stem cell transplantation, because remember, the CHOEP was only for patients younger than 60. So the majority of those patients actually had stem cell transplantation. So we don't really have prospective data looking at how patients do with CHOEP alone without stem cell transplantation. I mean, we just have our little experience, but nothing really short of prospective randomized study.
Here's one for Dr. Foss. Mycosis fungoides relapse post-transplant. Similar to the earlier one. What therapy would you recommend? You talked a little bit about that, but if you want to elaborate.
Yeah, I think you can also look at some of the newer drugs. And I actually have I talked about a patient on the Aztec study who relapsed and responded to that, brentuximab. Sometimes you have to use a gemcitabine-based regimen if they have a fairly aggressive relapse. I think it really just depends on the disease. I mean, obviously, we'd like to use immunomodulatory therapy. So if we can get DLI, that's a consideration. Sometimes weaning off immunosuppression works. Sometimes we give radiation after. It really just depends on what the manifestations of disease are. But I've seen patients come back with very aggressive disease after transplant, even more aggressive with. You have to watch out for visceral involvement. I've had a number of patients who had no visceral involvement before. And then for some reason, because of all the kind of immune chaos associated with allotransplantation, they develop these cells that escape and they have extensive visceral involvement. So I don't think anybody really has a good answer to that question, Steve, because we as a community haven't really explored the whole kind of role of allotransplant and how you manage patients after. And when you taper immunosuppression, if it's like AML, where you try to do it early, and what is the role of any kind of adjuvant therapy. So that's a whole open area that needs to be explored.
Here's one for the panel. Should CD38 targeting agents be used in AILD? So AILD is the old term for AITL, so I'm assuming this person's older than me. That was for the panel. So CD38, again, in T-cell lymphoma.
I've not used any.
Yeah. Yeah, I think there's little data. There's preclinical data that I think, as you mentioned, that they often express CD38, and at least you can target them in cells, either with antibodies or maybe combinations with other therapies. But I don't know of any sort of robust clinical data. It's not something that we have done off study. There's some anecdotes for NK lymphomas responding to CD38. I think there's a New England Journal case report. This is for Dr. Pro. What's the rationale for duvelisib in PTCL?
So I think you have shown the data. First of all, we have a molecular profiling in some of these patients that shows the PI3 kinase pathway being a very, very important pathway in the pathogenesis of some of these disorders. So it makes sense that if you have an inhibitor to use it. And I think early data, the phase 1 study that was open to a number of hematologic malignancy actually did show a signal in both CTCL and peripheral T-cell lymphoma. And building on that, that's why the PRIMO study was then designed. And I think, this is one of the agents that I think is the most effective in the treatment of relapsed refractory patients. And so makes sense to try to move it again up front. And this will be one of the arms in the Alliance study. I think the major problem with using this drug is identifying patients who are likely to respond, because so far we do not have a biomarker that can really help us to decide who are the patients likely to respond.
Here's for Dr. Foss, there's another easy one. What do you use for refractory pruritus? I assume this means in CTCL.
What do you do for refractory pruritus? It's a good question. We've used gabapentin, we've used naltrexone. Patients come in and say that they've used lavender oil, like they have, other kind of homeopathic things. But I think the bottom line is that there's really no good answer. And what I tell people is you need to treat the disease. Effective treatment and management of the disease will improve the pruritus. So, that's
the major problem, though, Francine, is that, as you well know, sometimes, tumor burden doesn't really correlate with how severe is the pruritus.
Exactly.
So some patient can have very little disease and have this excruciating problem with the itching. Yeah. And it's affecting their quality of life. So I really hope one of these days we can come up with a better regimen.
It's an area which requires, I think, a better intersection between kind of the dermatologic community that's managing itch-related diseases and the oncology community.
Here's another challenging one, but I think important one for both of you. With patients with greater than or equal to stage 2B disease with CTCL, so tumor or higher, that are cycling through monotherapies, when do you start considering stem cell transplant?
So that's a good question. For patients who present with advanced stage disease, who have big lymph nodes, a lot of tumors, and kind of extensive blood involvement, pretty much that they're going to end up getting a transplant in the relatively near future. I try to approach those patients up front, at least with the concept that this might be something that we're going to think about, so that they don't get surprised later on and think, oh my God, I failed everything and now I'm going to do a transplant. So certainly that group of patients, but patients with kind of advancing patch plaque tumor, kind of advancing disease, who cycle through, and many of these patients cycle through all those drugs, all those single agents that are listed in NCCN. They just kind of go through them, and they have responses that get shorter and shorter, or they don't respond. So I think those are the patients that you start to kind of note that their disease is relatively chemo-refractory or not really responding to your modalities. And those are the patients I think you should start thinking earlier rather than later. The problem is with this disease, because you do have large cell transformation, that if you wait too long and they get very aggressive disease, it can be a lot harder to manage it. So I think the answer is really, looking at the kinetics of the disease in that patient. And when you sense that it's moving quickly and it's not responsive to your modalities, you've been through 3 or 4 systemic therapies, you really need to start thinking about it. But there are certainly those patients who come in with like stage 4B disease with extensive visceral involvement, looking like an aggressive PTCL, and didn't respond to the first 4 cycles of EPOC, and that's a patient that needs to go sooner rather than later to transplant. Barbara, I don't know what you're...
Yeah, no, I agree 100%.
So this should be an easier one. Are you using belinostat more now since FDA vindication in relapsed refractory PTCL was withdrawn for romidepsin?
I think the schedule of administration of belinostat, it's a little bit troublesome. As you know, patients have to come to clinic 5 days. So I have not been able to really convince patients to get the drug. And it's not something that physicians in private practice also are able to do just because of the schedule. I wish we had a different schedule, or we looked at a different schedule. So I have very limited experience with belinostat. I do prefer romidepsin just because it's weekly, and we will have to see now.
This question was actually for me. What is the rationale for using a PI3 kinase inhibitor in relapsed refractory PTCL versus first line? Well, I would say almost all the data we have right now is in relapsed refractory disease. So as a single agent, we have responses that I showed, at least with duvelisib, it's 50%. And some of those are complete responses. Some of those are durable. So that's in sort of either a CR to allo setting or a palliative setting where you're trying to manage disease. I think that you look at a response rate like that in the relapse setting, and if there's a CR rate to a single agent in relapse refractory disease, could that translate into higher CRs in the upfront setting? And CR, is probably a precursor to cure. So I think that's sort of the concept, is if we add active agents up front, could you cure more people, which obviously is better. So I think that's the rationale. There's not, to my knowledge, any understanding biology that PI3 kinase pathway is more important in relapse disease versus upfront. I don't have any data to suggest that. So it's more taking active agents and moving them into earlier lines of therapy for more impact on patients' course. what would you offer off-trial recommendation for an 82-year-old with relapsed AITL? I'm giving all the easy ones to Francine. Dr. Foss, Dr. Pro, you want to take that one?
I mean, I think romidepsin is a very active agent in relapsed AITL. I've shown you that some of these patients can have very durable responses. And, you can use kind of a maintenance type of strategy that was built in the pivotal trial where patient will be on the drug for up to 2 years. Maybe getting one infusion every month. I think the major problem with romidepsin when you use it in older patients is tolerability of this drug. And so by spacing it out, actually, you can improve that. So definitely, I think in the absence of a clinical trial, romidepsin, it's a pretty active drug in AITL.
If they were CD30 positive,
you could definitely use also brentuximab. Again, response rate was lower than systemic anaplastic large cell lymphoma, but definitely you can.
Yeah, we ran into that exact case. That exact question was posed to me last week with a low level of CD30 positivity. Would you use brentuximab or would you use romidepsin?
I think the major thing with brentuximab in older patients, as you know, it's rare that you can actually give them more than 6 cycles of chemotherapy because then peripheral neuropathy, becomes a major issue. And so for someone who is not a transplant candidate, if you can keep them on a treatment for longer time, I think it will be more beneficial probably. That's why I would favor romidepsin over BV if they have a response.
Thank you very much, Dr. Horwitz, Dr. Foss, and Dr. Pro, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Addressing Clinical Challenges in T-cell Lymphomas Through Biomarker-Driven Therapy, and to download the PDF associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.